My name is Olatilewa Amusu, and I'll be the moderator for today's webinar. On behalf of the College of Nigerian Pathologists and her partners, I welcome you. And this webinar is part of the series on the laboratory-clinic interface. The topic for today is Bridging the Gap, a meeting between pathologists and clinicians. And we hope that it will provide medical practitioners information on the many roles that pathologists play and how to derive the best service from your pathology department. It would also enable us to hear the perspective of our colleagues who use the services and thus provide pathologists with an insight to what our clients expect. Most of the untoward effects that we have or incidents we have in healthcare when investigated actually reveal a root cause of poor communication. So we know that communication is the first step to build an effective patient care team. And I'm hoping that this webinar would be an opportunity to provide that communication between the laboratory practitioners and other specialties. This morning we have representatives from the 4 specialties of pathology, clinical chemistry, hematology, histopathology and morbid anatomy, and microbiology and parasitology. And they will be able to give us talks on these specialties. Then we have 3 panelists who are going to talk from the perspective of clients of the pathology department. Thereafter, we'll address questions and contributions. And then the president of the College of Nigerian Pathologists would give us some closing remarks. We will be starting with the first presentation from chemical pathology. Our presenter is Dr. Oyetunji Shoriyan. Dr. Shoriyan had his MBBS degree from the University of Ibadan. He's a member of West African College of Physicians in Lab Medicine and also a fellow of the Postgraduate Medical College, Faculty of Pathology with specialty in ChemPath. He also has a certificate in Laboratory Quality Management System from the Clinical Laboratory Standards Institute, CLSI in the USA. He's a member of the Working Group on Guidance for Implementation of Custom-Made Genomic Panels of the International Federation of Clinical Chemistry and Laboratory Medicine. He is a senior lecturer and consultant chemical pathologist in the Clinical Pathology Department, College of Medicine, University of Lagos, and the Lagos University Teaching Hospital. Please.
Good morning, everyone. It's my pleasure to speak to you today about my specialty, chemical pathology. So I'll be sharing with us about chemical pathology in trying to bridge the gap at the clinical laboratory interface under the following outline: brief introduction, definitions, scope, our subspecialties in the discipline, and then the role of the chemical pathologist, a brief on challenges at the laboratory clinical interface, and summary. So by way of introduction, we know that pathology is the medical specialty that provides scientific foundation for medical practice. And the pathologist is first of all a physician, a clinician, who specializes in the diagnosis and management of human disease using laboratory methods. And fundamental to this discipline is the need to integrate clinical information with physiologic, biochemical, and molecular laboratory studies, together with observation of tissue alteration in trying to make diagnosis, screening patient, making prognostication, and monitoring response to treatment. So the pathologists in the hospital and clinical laboratory practice as consultant physicians, developing and applying knowledge of tissue and laboratory analysis to assist in diagnosis and treatment of individual patients. So a brief on definition. Pathology is the scientific study of the cause, origin, and nature of disease, including the changes occurring as a result of disease. So in a nutshell, it is the knowledge and study of disease processes. And it has 4 main branches: chemical pathology, which is my own discipline, hematology and blood transfusion, anatomic pathology, medical microbiology, and parasitology. So coming home to chemical pathology now, an offshoot of chemistry as a scientific subject. So chemistry is the knowledge and study of composition, properties, and reaction of substances. And in our context of chemical pathology, it's an offshoot of biochemistry, which is the aspect of chemistry that pertains to life, living organisms. And in our context, human beings. So chemical pathology is the branch of pathology that is concerned with biochemical basis of disease and the application of biochemical and molecular techniques in screening, making diagnosis, monitoring response to treatments, and prognostication. So it has several synonyms: clinical chemistry in the US, Canada, that is more popular than chemical pathology. They are more used to clinical chemistry. In clinical biochemistry in the UK and a few other places, Canada, Australia, and then metabolic medicine. Another subspecialty of chemical pathology is metabolic medicine, which deals with metabolic disease in all its manifestations. And it has 5 main modalities: lipid disorders, cardiovascular risk, diabetes, nutrition, inborn error of metabolism, bone and mineral disorders. And this metabolic medicine as a discipline is actually well developed and mainly applies to the UK, United Kingdom, and Australia, where there is a dual program. If you are doing fellowship in Royal College of Pathology, you enroll for metabolic medicine, you do part 1 of internal medicine subspecialty. You have become a member of the Royal College of Physicians, and then you continue your pathology residency. Here in Nigeria, we still majorly chemical pathology. We've incorporated some metabolic components at the level of part 2. Post part 1, our senior residents go to internal medicine for a minimum of 3 months rotation, mainly in endocrinology, nephrology, and other specialties. But those 2 are the posting has bias for endocrinology, clinical endocrinology, and nephrology, while the remaining period, and they do a general rotation in internal medicine. So why is this discipline important? We know that before any deranged morphology, or function, there is always, in any disease process, first a deranged chemistry. So many illnesses are reflected in disturbance in biochemical processes in the body. Before you start seeing a tumor, a swelling, or before starting being feverish and all that, there is a derangement at the molecular level in terms of deranged chemistry. So chemical pathology brings together science and medicine, and by understanding the chemistry of body fluids and monitoring these, lab professionals can tell whether a patient's organs are working properly, and make proper diagnosis and recommendations as per treatment, and further investigation that will help in cases when diagnosis is not clear-cut, and then instruction as per patient preparation, requirements to guarantee pre-analytical quality of the process, and then that will determine the analytical and post-analytical results. So what is the scope of this specialty of pathology? Suffice to say that quite a number of people have a wrong perception that chemical pathology is just limited to providing some automated instruments that can do electrolytes, maybe liver function, lipid profile, a few routine chemistry, and that is chemical pathology. In fact, most of the CMDs, chief medical directors, and hospital managers seem to have such perception, and it's actually a wrong perception because it's a short-sighted view of chemical pathology. Chemical pathology is much broader than just routine EIUs and liver function, lipid profile. And just because you have an auto-analyzer doesn't mean you have a solid chemical pathology services ongoing. So it has several subspecialties: lipidology, clinical endocrinology, that have to do with diabetes, hypertension, and several other endocrine disorders, human nutrition, artificial parenteral nutrition, toxicology, drug of abuse studies, therapeutic drug monitoring for renal transplant patients, and other drugs that have low therapeutic, narrow therapeutic index, immunology, inborn error of metabolism, molecular diagnostics, proteomics, metabolomics, tumors and other biomarker development and clinical utility of those markers, and then bone and marrow metabolism. It's not an exhaustive list, but it captures most of the scope or subspecialty of chemical pathology. So it goes beyond just routine electrolyte and urea creatinine. So we know that more than 75% of medical diagnosis require the service of the laboratory. So laboratory, especially chemical pathologists inclusive, play a key role in this. So doctors in chemical pathology have dual responsibility: provision of reliable analytical service and a clinical role, which is not only on advising on management of patients with metabolic disturbances, but in several countries now, in the UK, Australia, and some other countries, that increasingly having direct responsibility for patient management. They have their own metabolic ward, and even in Nigeria here, we have models that are like in UCH. They have a metabolic ward, dedicated metabolic ward for chemical pathology with their nurses and complements. So they are increasingly having direct responsibility for patient management in outpatient clinics and on the ward. Here in Legal University, where I practice, we've been running obesity and metabolic clinic for more than 2 decades for the hospital every Mondays. Now, we don't have dedicated ward here unlike UCH, but we do see patients from time to time on the ward. We receive consult and we liaise in collaboration with our clinicians and surgeons and other clinical specialties in managing patients on the ward as required. So many of these biochemical analyses are performed on automated instruments and some on some manual instruments, usually operated by technologies where in Nigeria they prefer to be called medical laboratory science. Management of the process, even though they are the one that run most of the routine tests directly on day-to-day basis, management of the process, including the staff, their training, competency, certification, and all that, assurance of quality, provision of guidance on selection of tests, assessment of the significance of the results, particularly in tests that are exoteric and not people are not so familiar with the requirement for such tests, and sample collection requirements, and they'll run even sometimes to directly assay. Clinical pathology also can assay anything that the subordinate medical lab scientists can do, though that's not our daily routine function. It's more supervisory. They have the direct job description to man those equipment, but before a chemical pathologist can function efficiently, so interpreting results and troubleshooting clinical information with the analytical phase of the process, you must understand the chemistry behind those tests, how to perform those tests, or what are the reagents and what can interfere and all that. That's why during residency training, we expose our residents. It's a requirement by both postgraduate colleges for them to do bench work. They do call duties, they do emergency analytes and routine analytes, so that they are not going to graduate as consultants to be doing that on a daily basis, like working like a medical lab scientist on the bench. But they, by going through that process during training, then are exposed to the nitty-gritty of the whole laboratory part of workflow, the analytical phase, the post-analytical phase, and pre-analytical phase. I can then match that with clinical information to interpret result properly, as we'll see later as we proceed. So the role includes laboratory management, but you can see that laboratory management is just a dot among the roles of a chemical pathology. We are not primarily medical lab scientists to sit down in the lab every day. We have several other functions from those scope that I highlighted, the subspecialty that I highlighted, that goes beyond just laboratory management. So, but as a pathologist, the buck stops on the table of the pathologist. The pathologist legally takes final responsibility for every result emanating from any laboratory. So, laboratory management is one of the core mandates of the chemical pathologist. Provision of interpretive comments on results, especially results that have one or two abnormals. Clinical liaison, like advising on further investigation or management of patients that are found to have biochemical abnormalities or routine testing. Then clinical consults. From my experience, we receive a lot of consults from intensive care units concerning electrolytes derangements, because in correcting electrolytes, and from the wards too, even from surgical ward, neurosurgery, especially when they do craniectomies and all that, and their patient come down with diabetic insipidus because of the posterior pituitary issues. So clinical consults from ICUs, the ward, and other part of the hospital, running clinics, obesity clinic, like I said, we've been running that here for over 2 decades now. Diabetic endocrine clinic, that's lipidology clinics. For when I was in South Africa for my laboratory quality management training some years ago, in South Africa, where in Cape Town, they actually had a lipid clinic, different from the other clinics that chemical pathology run, a lipidology clinic, and they jointly run that with the internal, the cardiologists. So, and then bone and marrow disease clinic, and then provision of dynamic function test services in collaborations with physicians. We have a lot to offer physicians in this area in terms of standardization of those tests, developing guidelines, standard operating procedures for those tests. Then the analytical phase of those dynamic functional tests to analyze those hormones, like a high dose or low dose of dexamethasone suppression tests, insulin tolerant tests, water deprivation tests. These are some of the dynamic function tests. Dynamic function tests are the confirmatory tests in chemical pathology that tells, as far as endocrinology is concerned, where the abnormality is, because baseline hormone measurements in the blood and other body fluid can be deceptive sometimes because of other factors like circadian readings and interferences from drugs and physiologic process like pregnancy and all that. So sadly, most chemical pathology departments in our setting here are cut off from being involved in these. Well, not consciously, but maybe subconsciously somehow in most hospitals, teaching hospital settings. The internal medicine physician, the endocrinology just sit on that. And I mean, the patients stand to benefit more if we collaborate with each other, and that's better synergy between the chemical pathologists and the endocrinology, the internal physicians, internal medicine physician, concerning provision of dynamic functional test services in the hospital setting. Quality assurance of the whole laboratory part of workflow. That means not just the analytical phase, the pre-analytical phase. In fact, more than 60% to 70% of laboratory errors, as research have shown, are actually in that pre-analytical phase. So even before the result, I mean, the sample gets to the machine to be analyzed, and before the result is generated, more than 60 to 70% of errors already have happened pre-analytically. And so analyze it in the moon or anywhere with best facilities, most sophisticated esoteric facilities, they'll still get the wrong results. It's garbage in, garbage out. So quality assurance is assuring quality in the whole laboratory part of workflow, not just the analytical phase. It's quality control that takes up just the analytical phase, what happens inside the lab itself. The whole happens outside of the lab before the sample gets on to the analyzer is even more important, because that determines the end product, and a lot of wastages and medical legal issues can be avoided if chemical pathologists are involved in quality assuring the whole process of laboratory part of workflow, pre-analytically, analytically, and post-analytically. Also, development of new tests and validation of test methods is a key function of chemical pathology. Point of care tests oversights in several health facilities in our setting here in the country. So many POCTs, everybody is using glucometers on the world, in A&Es and all sorts of places, but nobody is monitoring these devices because a point of care device can generate a digital result quickly, it doesn't make it right. You can be precisely wrong. There's a difference between precision and accuracy. Most of these devices are precise, but might have issues with accuracy of results. So this from time to time, there is need for correlation of the result from those point of care devices with the result from the central lab using the standard validated methods and techniques and instruments inside the laboratory to ensure that whatever the point of care device results are actually valid. So the chemical pathology should be in the forefront of the point of care testing oversight in the various institutions. People should submit those devices for validation from time to time to be sure that what they are churning out is still correct by correlating with the laboratory standard laboratory methods. So each institution is supposed ideally to have a point of care testing committee, and the chemical pathology has to be an integral part of that. Introducing and carrying out specialist analysis. There are some analysis that we can do directly, even though we have subordinates that work, assist us in the lab. The lab is the hub for several activities and several professionals. But the chemical pathology has the competence to directly do those tests too, but not on a routine basis that every day you sit down on E&U to channel ER for everybody in the hospital. That's not our job description. That's for the medical lab scientists or technologists to sort out. But some specialist exoteric tests will involve the chemical pathologists doing it directly, like immunoelectrophoresis, for example, in most institutions that have that running, the chemical pathologists directly have oversight. In the UK, one of the startup plans, anything electrophoresis, it has to be directly done by the pathologist and reported. And there are several other exoteric tests that we can offer. Research collaboration to strengthen research work by our colleagues, the clinicians, because we can build quality into whatever results so that it will be valid and whatever data we are publishing, the integrity is assured, working with laboratory professionals. So instead of just asking the medical lab scientists to run research samples for you as a clinician, you have colleagues in the lab that can offer more quality and better guidance and advice. So research collaboration. So what are the challenges as I begin to round up at the laboratory clinical interface that we've seen? A lot, like I said, has to do with pre-analytical errors, collecting the wrong samples at the wrong time. Some samples require standardized time of the day because they have circadian readings, diurnal variation. Some even have pulsatile readings superimposed on circadian reading. The level of an hormone in the morning might not be that in the evening. I remember I keep on citing this example of some years ago. A colleague in public health, wife had an infertility problem and took a sample, was sent to the lab. We investigated and shown out the results and commented, but they had issues with the result. They felt it didn't correlate with the clinical picture. And the hormone involved was prolactin, and we know that it has diurnal variation. The time of collection matters. But on the form, it didn't indicate the time of collection. So we gave him the result and we put the reference interval for the standard time, which is the early morning, because there was no information. We are not in science. So filling the form is a key component of guaranteeing valid results. They have to put all the necessary information, clinical information that are required. We've seen, forms sent to the lab, no age, no sex, even age, they'll put adults. A 16-year-old is an 18-year-old is an adult, a 70-year-old man is an adult. They won't have the same post-specific antigen level. So writing adult there, it doesn't suffice and will affect quality of the comment, interpretive comment that will follow. We need information to make interpretative informed judgments. So the format to properly fill. We've seen hormonal assay for fertility profile coming and they didn't put sex. And we know that testosterone in a man can be the same as testosterone in a woman, and vice versa for the other sex hormone. So pre-analytical errors, using the wrong, we've seen potassium of 20 something that's not compatible with life, and a patient that is eating on the ward, meaning they collected probably in a potassium EDTA bottle and decanted into lithium heparin and sent to the lab. So pre-analytical errors are very common. Analytical errors do happen. There's no lab that is perfect anywhere in the world. Quality management process just have to minimize to very minimum errors, but it can't guarantee complete elimination. So, but the analytical error are now very few compared to pre-analytical error. That's where the bulk of the problem is. Then reference range issues, some tests, some clinicians might not be familiar with SI unit used for some analytes, and that changes the reference range. Some enzymes are temperature specific, so different method for the same enzyme and have different reference ranges depending on the temperature used. So those kind of advice, the chemical pathologists can support our clinicians to properly guide them and interpret results and put the appropriate comments. Units of measurement, conversions of units sometimes can also be an issue. I've mentioned lack of or inadequate clinical information on request form, clinical consults referral, and I will end by projecting about 3 cases very quickly in this area to highlight the usefulness of chemical pathologists in this area. Of course, sometimes we have delayed turnaround time due to instrument downtime or supply chain issues and other things, emergencies outside the control of the laboratory. These are some of the common clinical settings that require intervention of clinical pathologists. Most of the consult we receive my own practice here has to do with water and electrolytes issues, acid-base issues, and a few on more specialized issues like endocrine issues and others like toxicology and therapeutic drug monitoring. So these are real cases. A 30-year-old female that was operated had bilateral ureteric cannulation, and post-op, and it had salpingectomy done. Post-op, the effluent, the drain they put, they had some effluent coming, and the surgeon, the urologist, was not sure whether that was urine leaking from the bladder or peritoneal fluid. So, and they didn't want to, that was post-op, patient was already on the back on the ward, and they just didn't want to rush to the theater, open up again, and do a major laparotomy without knowing what to expect. So they called us and wrote a consult and were involved. So we asked for a sample of the urine, analyzed the urea content and the creatinine of the urine, and calculated the ratio of that to the effluent that is coming from the drain that they applied post-op. And this was the result, and the interpretive comments as projected. From that analysis, we were able to advise them appropriately that this effluent that's coming from the drain is urine. So they know that they knew that they are going to open up and they have to do bladder repair just from the biochemical tests. And that was very helpful to them, and the patient recovered fully and went home. The results for that particular patient showed that the ratio of urine to drainage fluid creatinine was less than 3, which is strongly suggestive of urinary leakage. So that is just one. This one is about a pre-analytical issue, a CSF. CSF is an emergency. It's one of our emergency analytes in chemical pathology. Yeah, I'm rounding up now. Around the clock, we must generate result within minutes. We cannot wait for the, it's an emergency. So this came in, and you can see here that the blood glucose already was in the hypoglycemic range, and the CSF glucose was even higher than the blood glucose. So there was a problem. Of course, it was a periodical problem. They used expired fluorodoxalate bottle for the specimen, so it couldn't preserve the blood glucose level. And so CSFs are not trafficking of the plasma. Ideally, should not have a glucose is higher than that of the plasma. It should be about 2/3 of that of the plasma. So we're able to troubleshoot and and CSF is a precious specimen. It's not a specimen you want to waste. So, but unfortunately, they have to go for another lumbar puncture to get another sample using the proper bottle that is not expired. This is also a periodical issue, a potassium of 28.1 in a patient that is, very fit on the ward. It's not compatible with life. The doctor who collected into a potassium EDTA bottle, and we know EDTA chelates calcium. So calcium is, that's why calcium was very low. Potassium was very high, but it was a potassium EDTA. They already had a loss of potassium inside the anticoagulant used. So in summary, I've been talking about chemical pathology, which is one of the discipline, the four discipline of pathology that has to do with biochemical basis of disease and using laboratory methods to look at the biochemical profile of a patient in making screening for the presence of disease, making diagnosis, monitoring response to treatment, and even prognostication like a cardiovascular risk using cholesterol, calculating cardiovascular risk for such patients. And chemical pathology is a discipline that leans so much on clinical information from clinicians, and our outputs actually a lot dependent on the input from requesting clinicians. It provides a platform for research collaboration and collaborating with, strengthening the clinical laboratory interface would definitely improve quality service delivery to our patients. Thank you all for listening.
Thank you very much. Thank you, Dr. Shorin Manga. Dr. Manga, Bello Manga is a consultant hematologist. She's an MBBS, MPH, and a fellow of the Postgraduate Medical College in Pathology. She is a senior lecturer in the Department of Hematology and Blood Transfusion, Faculty of Basic Clinical Sciences, Kaduna State University, and a consultant hematology to the Barao Diko Teaching Hospital, Kaduna.
Good morning, everybody. Thank you for inviting me for this program. I would like to say a big thank you to the previous speaker who said a lot about pathology and the role of the pathologist. So I'm not going to dwell much on that, and I'll just dwell more on the role of the hematologist in bridging the gap and between the pathology discipline and clinical practice. So what is hematology? It is a branch of medicine that involves the study of the causes, diagnosis, treatment, and prevention of diseases of the blood. And this has to do with red blood cells, white blood cells, platelets, in relation to the counts and the morphology, then clotting and bleeding disorders that has to do with the plasma, and then of course, transfusion of blood and blood products. So the hematologist actually wears a lot of caps. The hematologist is a medical doctor who specializes in diagnosing and treating diseases affecting the blood and bone marrow. And he or she provides clinical care to patients, either directly as primary hematology patients, because there are a lot of hematologic disorders. So we give care to patients directly. We see them on the wards. We run daycare clinics. We run regular clinics. Could be there are different specialties. I'll talk about it later. And then we also contribute to the care of patients with non-hematologic disorders with other colleagues as consultative hematologists. So most of the time you see us running around attending to consults from the surgical wards, from the O&G. Those are our great customers. They always call us, pediatrics, everywhere. There are times that when the hematology team goes on ward round, you actually end up going to every part of the hospital, because one way or the other, you have a patient in every ward in the hospital. So another cap that the hematologist wears is providing laboratory services. And there's a substantial amount of the work of the hematologist involves diagnostic workup in the lab, and we review lab results, especially those ones that are flagged. We all know that most of our results are now automated, but even the automated machines cannot tell you everything. So once they detect one problem or the other, the hematologist has to actually go back and have a look at it and look at the result and find out what the problem is. We also do a lot of diagnostic workup for disorders of blood and bone marrow. So that means we actually study the blood and then take a bone marrow aspirate and have a look at it and make our diagnosis from there. Then coagulation and other thrombotic disorders. Then we also provide safe and appropriate blood and blood products to patients. Another very interesting aspect of hematology is research, because over the years, a lot of advances have been made in hematology practice. And you'll all agree with me that a lot of those advances that have been made in, say, precision medicine, targeted therapy, actually started from hematology. We all know about the CML and how the TKIs were tyrosine kinase inhibitors were developed, and that has actually revolutionized the management of chronic myeloid leukemia and then other disorders as well. And then also the advent of monoclonal antibodies, which actually target specific cells. So research and medical advancement in hematology has actually helped in patient management as well. So hematology specialties can be broadly divided into the benign disorders, which have to do with hemoglobinopathies. Those are disorders of the red blood cell, the hemoglobin. And then, of course, there are other parts of the red blood cells, the enzymopathies, the membranopathies. Then we have anemias, we have coagulation disorders, which could be the hemophilias or the thrombotic disorders. Then we also have hematologic malignancies, which is a broad group of diseases that involve both solid and liquid malignancies of the blood. We have leukemias, lymphomas, we have plasma cell dyscrasias, which has a broad spectrum as well. Then we have others that could actually transform into hematologic malignancies like the myeloproliferative disorders, the myelodysplastic syndromes, and we also have immunopathology because we have transfusion medicine is a huge aspect of hematology. So why hematology? Hematology actually gives you the opportunity of completing the whole of patient care cycle. You start, as I said, we have patients that we care for directly. So they come into the hospital looking for a hematologist. So you start from the very beginning, you clock that patient, you take a history, you do a physical examination, and there and then, the beautiful thing about hematology is you take a blood sample, quickly run to your lab, do whatever you need to do at that point in time while the patient is waiting. And you can just come in and say, I have an idea of what is happening to you, and this is how we're going to go about it. So it's a really interesting field where you are able to integrate your clinical and laboratory skills at a go. And I think I must say, even with the whole of the pathology specialties, we have almost 100% of that integration, and we really love it. And the practice of hematology actually gives you that opportunity to develop long-time relationships with your patients. Most of the time, as I said earlier, we see patients all ages, so we can go to every part of the hospital. At times we actually start seeing patients from the NICU, that's the neonatal intensive care unit, or from in utero, because we follow up pregnant women and all that. So you find out that you start seeing a child as a baby, and that child actually grows in front of you and becomes an adult and all that. So you form that long-term relationship with patients, and you kind of, at times they don't even really need to tell you what's wrong with them, because you know them. You're able to help them, not just medically, but in other aspects as well. And then as a hematologist, you can't help but work in a multidisciplinary team, because, as I said, your patients are long-term patients. So that at one point or the other, you need the help of the nurse, the psychologist, the pediatrician. It could be the orthopedic surgeon and all that. So we kind of work together most of the time, putting the patient in the middle and ensuring that everything is done to the benefit of the patient. So I'll just take one aspect of one of the hematology tests that we do often, and I can confidently say that there's probably not a single person that walks into a hospital and that doesn't have a full blood count done. And to me, I always tell the students that your full blood count actually tells you a story. And it's the most common investigation done in every center. And it's usually part of an initial diagnosis for a non-hematological disorder. Somebody might just send a patient for a routine full blood count. And by the time that full blood count is completed, you have a different story to tell the clinician. I remember a patient that came to us during our residency in Zaria. She just came for a routine blood check. And by the time we reviewed her blood film, lo and behold, she had lots and lots of erythrocytes. This patient had hereditary erythrocytosis. She had no idea. She didn't have symptoms or anything, but just by doing a full blood count and looking at the film, we were able to do that. And then even some non-hematological disorders like liver disease or kidney diseases or something like that. By just looking at the film, you'll be like, why are those cells? You just get curious. Why do we have echinocytes in this patient? Then by the time you trace back, you now find out there is one renal problem or the other. So based on the full blood count, you are now able to advise on further tests that would actually clinch the diagnosis. So I think every clinician should take the full blood count seriously. And it doesn't help when clinicians always say, we just want a PCV. It's as if they're only interested in the hemoglobin of the patient, but there's a lot more to that patient's blood than red blood cells or hemoglobin. So I think the onus is on patients. So yes, I know there are times that you need the PCV as a matter of emergency, but whenever you request for a PCV, always kind of request for a full blood count so that you now see what other things are, what things are happening with the other blood cells. A patient might be coming with a low PCV all the time, and all you want to do is transfuse. But if you don't do a full blood count, you might not know that that patient actually has a pancytopenia, meaning red blood cells, white blood cells, and platelets are all low, and that could be an indication of a bone marrow problem. So that full blood count really tells you a story. I think the crux of this presentation is really to see how the clinicians can reach out to us pathologists. So as a hematologist, I think clinicians should make use of us more often than they do now, especially when it comes to maybe for the surgeons, when they're preparing their patients for surgery. You don't just say, okay, we're going to go I'm going to do a hip replacement. I need 5 units of blood or something like that. Plan properly, especially for the elective procedures. We all know the hazards of blood transfusion. Just tell the hematologist that I plan on doing a surgery on this patient in the next 2 or 3 months. What do we do? How do we build up this patient's blood level, HB, so that he doesn't need blood transfusion at the end of the day? And the patient, the hematologist will actually help you in maybe prescribing hematinics, following up that patient and all that. And at the end of the day, you kind of spare your patient from blood transfusion that has all the hazards that we all know could occur. And then we also, a lot of times, clinicians base their maybe transfusion trigger on just the HB or something like that. We really need to look at the patient in total. It's not about having a low HB. A low HB in a patient that is elderly, doing nothing at home or, or in the hospital already, that patient is not going to need a lot of activity and all that. You don't really need to expose that patient to the hazards of blood transfusion. So you can manage that patient without having to transfuse. But at times, clinicians kind of rush into transfusing. But when you call in a hematologist to help you, you'll be able to see that you'll be able to you take care of that patient without having to do some things that are not really necessary. Of course, when if the need is there, nobody will stop transfusion. Then performing specialized tests, as I said, once you engage a hematologist in the management of a patient, you might not even think of further tests to do for the patient to help you make a diagnosis. But that hematologist knows those specialized tests like the bone marrow test, aspiration, looking at the cells and all that, or maybe just simple serum ferritin that could help you clinch the cause of an anemia. Then one thing that we really, really need to address with the other colleagues is the sample collection, transportation, storage for quality assurance. My colleague in chemical pathology stressed on this, and I can only stress further, because as he said, if you bring in garbage sample, then you have a garbage result. And the pre-analytical factors that affect sample the result is actually very, very important. And most of those pre-analytical factors occur either on the patient or in the process of coming to the lab or in the process of taking the sample and all that. Simple use of appropriate sample bottles and the quantity of blood that you put in that sample bottle makes a difference. I can give you an example with coagulation tests. There's a ratio of blood to the anticoagulant or coagulant in the bottle. That's the sodium citrate. Once that ratio is not maintained, then you are not sure of your result. And then at the end of the day, we all know that you might have to, maybe that patient is on warfarin or something, you need to do some drug adjustment. So at the end of, you might really not be helping the patient if you don't do all these things well. And then another thing is I have come to realize patients or clinicians, some clinicians, especially the younger ones, just do some of these tests for the sake of doing it. They don't even know the implication of a low MCV. So interpreting the result, or maybe they see somebody with an anemia, severe anemia with a very high ESR, and they're like, oh, this ESR is high, there's a chronic inflammation going on and all that. But it's very simple. If you see something you're not sure of, just call the hematologist, and then we'll be able to shed more light on what the result you are seeing. So I want to stress that working together is a key. This is a study that was done in Ghana. The title of the study is Implementation of a Multidisciplinary Care Reduces Maternal Mortality in Women with Sickle Cell Disease Living in Low Resource Setting. So this, the crux of this article is it was now found that patients or women with sickle cell disease, the mortality in them in Ghana was really very high, about 10,000 or more per 100,000 live births. So the obstetrician, the hematologist, the anesthetist, nurses, and I can't remember the third person, all came together to see whether there was a way that they could profile or come up with strategies that would help in reducing this mortality, very high mortality amongst pregnant women with sickle cell. So you see, the obstetrician didn't say, these are pregnant women, they're my patients, so I'm going to do it alone. The hematologist didn't say, these are patients that have a hematologic disorder, sickle cell disease, so I have to take care of them alone. No, they all came together to see how they can help these women. So they developed a protocol that had simple measures, things like checking the blood pressure. And when they did before they did the study, they did a retrospective chart review and kind of found the major causes of death. And some of them were like acute chest syndrome and all that. So like they developed a protocol which highlighted things that they needed to do. So after the study, they now saw that the mortality rate had dropped from 10,000 plus to 1,100 and something. So you can see that working as a team and coming together, it's really, really the key. And this is something that we can all emulate in our different practices. We all have patients that have problems that cut across departments. So let's remove the barriers, work together, and I think our patient outcome is going to be much, much better. So in conclusion, the hematologists, actually the pathologists generally, but more especially the hematologists, I have to have some bias here, has both clinical and laboratory skills that they integrate into patient management, but we need a lot of support from our clinical colleagues, other clinical colleagues, so that we'll be able to help them better. And those things have been highlighted. You need clinical information, proper, complete clinical information. Age, you can't just say adult. It doesn't make sense. You can't say child. The childhood spectrum is so wide that a child can fall into any category. So it's very important for you to be specific about the age of a patient, and then whatever sample you want to send to the lab. If you are not sure of the bottle to use or the quantity of blood to put or how the timing is, in fact, at times, even if it's not an emergency, call the lab and find out if they can run that sample that day. If they can't, if really it's not an emergency, you can just leave it till when they say maybe the machine is on, because there are times that we have to do some things to be able to to maintain some of our machines. So find out, communicate. It's always very important. And as I said earlier, if you're not sure of anything, just reach out. We're all just a phone call away. And I can bet you we can drop whatever we're doing and give you the time that you require. So thank you so much. And I want to use this opportunity to remind us that June is actually a very important month for the hematologist, because 14th of June is the World Blood Donor Day, and then 19th of June is the World Sickle Cell Day. So I would like to seize this opportunity to remind everybody so that they can celebrate it in their own little way. Thank you so much.
Thank you very much, Dr. Belumanga, for the presentation and also for reminding us on the two major events that are happening next week. We'll then go on to the next presentation, which is going to be on histopathology. And our presenter will be Dr. Friday Ola. Dr. Ola is a general pathologist at the National Hospital, Abuja, with special interest in gastrointestinal, gynecological, hematopathology, and quality management systems. He is a member of the African Organization for Research in Training in Cancer, Africa, and a member of the Society of Gastroenterologists and Hepatologists in Nigeria. So Dr. Ola, please.
A lot has been said already, so I would skip some of the things that I have on my slides as well. My own topic is the role of the anatomic pathologist in clinical medicine. I am going to use this outline here in my presentation. I will first start with some scenarios to bring perspective to the discussion. We are currently witnessing a pandemic, the COVID-19, and the earlier treatments and the modalities for treatments that were started initially when the disease first started. We're talking about ventilators and use of chloroquine and then use of aspirin. A whole lot has come and a whole lot has been settled so far, but still more needs to be settled. Part of it was that autopsies were performed after some time, and we now know better the nature of the coronavirus. We now know better that most of the patients may not actually need some of the treatments that they were being given. Why? Because we have opened the body and we have seen how the organ changes that the viruses have caused look like. Another scenario, also presently a pandemic too of another sort, is the death of George Floyd. All we see on social media is a picture of a policeman kneeling on the neck of a supposedly heavily built adult male. But at the autopsy, other findings came out. And surprisingly, there were two autopsy findings. Now, the two autopsy findings will determine, each of the findings will determine whether the main assailant, I'm calling him an assailant in this case, would go to jail for a first-degree murder, a second-degree murder, or a third-degree murder, all subject to the findings at autopsy. Whether it is that the man died of his own accord with support from the fact that he had a knee to his neck, or if the kneeling to his neck actually caused his death and when he actually died, whether he died in the ambulance on the way to the hospital or he died before he even was placed in the ambulance on the way to the hospital. An autopsy finding would tell that. The third scenario is one of an 18-year-old, and this one I hold, it clings heavily to my heart. An 18-year-old lady from Wukari who was brought into a hospital with breast cancer that had metastasized to the brain. She was already limp. The tumor had spread to the brain. She had convulsed several times before they even brought her in. So by the time we're making the diagnosis, it was already too late. What is the important thing about this lady? 2 years prior, she had a lumpectomy done at a general hospital and the sample was thrown away. In fact, in that particular case, the father of the girl had asked for the sample to be submitted for histology. At the time in question, there was a pathologist at FMC Jalingo but they didn't sign the sample for histology until the tumor had spread to a level where it could no longer be managed by the clinician. Another aspect that I want us to look at before I go on to the main meat of our discussion is the fact that there have been a lot of improvements in clinical practice. We have better investigative techniques. Surgeries can now be done through keyhole procedures. Investigations and MRIs are more specific. They have higher resolutions now. So in the same way too, you would expect that in line with all of that would come laboratory services that would support adequately so that the whole gamut would go together. In addition to that, we also have more expensive treatments. Better treatments, yes, but more expensive treatments. My previous speaker was talking about targeted therapy. There are targeted therapies, there are treatments that are very expensive, but there are treatments that we therefore need to be very specific and very sure of the diagnosis before we embark on. Because apart from being specific to the treatment, there are a lot of the drugs that we use have terrible side effects, and we need to be sure before we go on to use them. And we can now, with the help of the laboratory, be specific to the cells that we want to kill and spare the cells that we do not want to kill in our practice. Screening programs have improved. There have been a lot of studies about pap smear, whether pap smear is still useful or not. We still know that pap smear is one of the major success stories of the screening for a cancer. Others are breast cancer, we screen for prostate cancer, colorectal cancer, and other cancers today. And we need the support of the pathologists to be able to achieve all of this. How about patients' awareness and the fact that patients now present earlier? Of course, we know that our healthcare is moving at a slow pace, but we cannot underscore the fact that, we cannot exclude the fact that patients are much more aware now because of the internet, because of interaction with the rest of the world. Everything is moving at a faster pace now, so is the awareness of the patient as well. And so would also litigation coming. So therefore, we need the support of the pathologist, of the laboratory physician, to make precise, accurate diagnosis in order to be able to treat accurately as well. What is the meaning? Investigations are very expensive. The patients, because they are spending their money out of pocket, should actually have, and they deserve, accurate diagnosis and accurate treatment, cost-effective treatment. Again, even though in this country we do not use our data so much, our health data so much in planning, the epidemiologists, the statistician, the National Bureau of Statistics, and all public health planning agencies need the input of the hospital laboratory physician, especially the pathologist, in taking critical decisions. For instance, maternal mortality, infant mortality figures. If you go to the records in the mortuary of any hospital, you would hear a lot, you would get a lot of information, and you can use this information to actually decide and plan for the future. So we have a whole gamut as laboratory physicians, and especially as pathologists, to give. We can assess risk, we can screen patients, we can make differential diagnosis and actually measure the size and the quality of the tumor. We can actually tell you prognosis, we can prognosticate. We can determine what type of treatment would work and which one will not work. And we can actually monitor as you treat the patients. We can even do surveillance for you, disease surveillance. So there are a lot of things that the pathologist can do for you. So there is a whole lot that we can offer. And we're not achieving all of this because likely we do not, there's a gap in communication between the pathologist or the laboratory physician and the clinician. They've already defined who a pathologist is, but I'm going to just try and say who an anatomic pathologist is. An anatomic pathologist is a medical specialist who employs morphologic techniques to explain clinical signs and symptoms, to determine the cause of death, and to prevent evolution of disease. This is what one of our teachers, Rosai said in 1997. Anatomic pathologists and medical specialists were first of all doctors before we became pathologists. That means that the language of the clinician we understand. But beyond that, we also understand the language, the science of what happens to the tissue or what the disease is doing to the tissue or the organ or the organism. And we also understand what the organism or the tissue is doing to the disease as well. So it is that interface that we try to bridge as laboratory physicians and as pathologists. Let me draw here that the slight difference between the anatomic pathologist and the other aspects of pathology is that we deal with the tissue. They deal with other body fluids. And even when we deal with other body fluids, we are only concerned with the cells inside those other body fluids. So we deal with the cells and we deal with the tissue. Every other person deals with other fluids, all the other fluids. Okay, so that is what we do in anatomic pathology. What we do, we process the tissues, we examine them, we make diagnosis, and then we suggest treatments to the clinician. Have subspecialties too. Apart from it's not enough that we are laboratory physicians or anatomic pathologists, we also have subspecialization, although we have not very well developed down very well in Nigeria. So there's a surgical pathologist who deals with breast, gynae, and endocrine diseases. There is the gastrointestinal pathologist, the genitourinary pathologist, soft tissue pathologist, neuropathologist, hematopathologist. Hematopathology is different from hematology and blood transfusion. Hematopathologist is first anatomic pathologist who now goes on to spend a year or two to subspecialize in hematopathology. So in other countries, as a general, the moderator described me as a generalist. In Nigeria, we are mostly generalists, but in other countries, you are required to subspecialize most of the time. So I would probably be a neuropathologist and I will have no business looking at breast or gynae pathology. So sometimes my trainer, Dr. Jibrin, would say that we are abusing our brain, that we do a whole lot. Ideally, we should all subspecialize in different, but we don't have enough pathologists in Nigeria to be able to do that. So you see that a pathologist who is doing gastrointestinal pathology is also doing cytopathology, is also doing hematopathology, is also doing forensic pathology and all of that. We don't work alone as pathologists. We work with other healthcare workers. We work with the clinician first of all. In fact, we are taught that the pathologist is the wife to the clinician. It is a food that you bring from the farm that we cook. If the food is good, we'll cook good food. If the food is not good, we'll not be able to cook good food for you. So we work with the clinician. In fact, we are dependent on the clinician. The uniqueness about the practice of laboratory medicine is that we do not often have the chance to interface with the patient. So you, the clinicians, are our eyes, you are our ears, you are our fingers to feel and examine the patient. Therefore, it means that when you are filling that form, we expect you to include all the relevant clinical information, not that everything it should be filled with an epistolary page. No, we should have all relevant clinical information, whether it is the radiological investigations that have been done, what you found when you examined the patient, some critical questions you asked the patient and the answers they gave in terms of the physical examination, the history you took, the other laboratories tests that you had done before. For instance, if you are sending a liver biopsy to me, I would expect that I should get the liver function test. If you are sending a bone tissue to me, I would expect that I should have an idea of what the X-ray showed you, because I am blind other than what you tell me. Okay. We also work with morticians. We work with what we call pathologist assistants. And then we also work with laboratory scientists, medical laboratory scientists, they call them in Nigeria. In other countries, they call them medical laboratory technologists and technicians. So we work with a whole lot of people at our work. We don't work alone. Nigeria has a population of 200 million or so, thereabouts, but there are just about 70,000 medical doctors, greatly understaffed. Worse than that still is the fact that we have less than 500 pathologists. I stand to be corrected. I'm sure the number would have been updated or upgraded some more. But basically, we have about 500 pathologists. What does that imply? 500 pathologists serving 200 million Nigerians. That number is far too low So you'd expect that there will be a lot of burden, load work and all of that. I mean, loads of work and all of that. But in addition, we are still able to manage somehow. What roles do pathologists play? In our work, we do histopathology, like I said. Histopathology means we take tissue samples, solid tissue, and we look at them. We make diagnoses, we prognosticate, we decide or suggest therapeutic options, and we monitor the treatment. Let me use the breast as an example of what I mean by that. For the breast, first of all, to make a diagnosis, you can even use it to do screening for breast. After a mammography is done or a mammogram is seen and the patient comes with a breast lump, the physical examination, the patient is asked some questions, physical examination is done, patient is sent to do a mammography or some radiological investigations or breast ultrasound. The patient now is sent to us to do a fine needle aspiration cytology. We put a needle, the normal hypodermic needle into the lump, and we take some few cells by capillary action, we stock some and then we put them on a slide and we look at them and we decide whether we grade them, whether it is benign or malignant. If it is suspicious or malignant, a core biopsy is taken and sent to the pathologist, who looks at it, processes it, looks at it, and decides that this breast the lump needs to be removed, or a quadrantectomy needs to be done, or that breast needs to be removed if there are lymph nodes also involved, or depending on the stage that the tumor has gone. After the tumor is removed and brought, we still test again to determine that this tumor will respond to hormone receptors, or it will respond to the conventional chemotherapy, or it will respond to the trastuzumab HER2. HER2 is over-amplified, and therefore it will respond to trastuzumab or not. And then thereafter, we still monitor the lymph nodes for tumor invasion into other organs and other regions by biopsies sent to us. So we do a whole lot from start to finish. We are involved in the management of the patient. Cytopathology, we take gynae and non-gynae samples. Gynae samples usually would be pap smear. The woman's cervix is exposed, samples are taken, smears are taken from it, or exfoliative cytologies samples are taken, and smears are made, and then they are preserved and sent to the pathologist, who stains them and looks at them and decides that they are benign or malignant, and then suggests what should be done to it. Exfoliative cytology and aspiration cytologies and other samples taken from other body fluids and body cavities are also looked at as non-gynae samples by the pathologist as well. Then we are involved in intraoperative consultations as well. What do I mean by that? If you are in theater, you suddenly meet a tumor that you need to decide how far your surgery should go. The pathologist can help. Even in centers where they do not have frozen section facilities, you can still do imprint cytology, you can still do crush cytology. I know this has to be developed further, but those are things that are possible. And we can actually, while you are in theater, so that the patient doesn't have to go back a second time. You have removed the tumor, but then it turned out to be malignant, but then you didn't remove everything. So we don't want that to be the case. So in trying to help reduce costs and morbidity for the patient, we are able to offer intraoperative consultation as well. How about drug monitoring? A patient that is on a hematology patient who is on treatment for, say, leukemia, acute myeloid leukemia, or we wonder that they may have spread or advancement or progression of the disease. And we can take cytology samples, fluids from the CSF, samples from the pleural fluid for different types of diseases, and we look at them and decide, is there presence of tumor in them or not? We can check for a woman with an ovarian tumor, whether from the acidic fluid that you send to us or the pleural fluid that you send to us, we can decide whether there is a tumor coming or not, or whether there is a tumor or not. So those are the areas where we're involved in monitoring. We can also monitoring for transplant patients as well. Recently, we received samples from one of the private hospitals in Abuja for a patient who had undergone renal transplant. We can monitor transplants, whether the transplant is rejecting or is staying. We can monitor them if you take some small biopsies for us as well as pathologists. Multidisciplinary team meetings. tumor boards and clinical pathologic meetings are a routine in National Hospital. For tumor boards, National Hospital is an oncology center, one of the centers of excellence for oncology. So we engage in tumor boards frequently. What do we mean by that? A tumor comes, tumors behave in different, ideally we should actually meet on all cancer patients, but sometimes that is not possible. Well, most of the times we meet on patients where the clinician comes with their own information, the radiologist is present there and makes contributions, the surgeons are there, and the pathologist is there as well with the report. Everybody makes inputs, and the patient at the end of the day, there has never been a tumor board meeting we had that did not get positive results for the patients and improvement in the quality of care of the patients. Okay. Then we oversee administrative duties as well. We are the head in the hospital, and so we are involved in budgeting, in equipment maintenance, in supply. The whole gamut of quality management is on the shoulders of the pathologist. Maintenance of disease and cancer registries are also done by the pathologist as well. We keep tissues in archives. So if any clinician needs to do any study, for National Hospital, we still have archival samples, the paraffin blocks from 1999 when the hospital was set up, we still have them in our registry, in our records. So we can still look at them and we can still study anything we want to study. It is also possible for us to actually keep and retain fresh tissues. As you, the surgeon, remove the tissue from the body, we can actually put the fresh tissue in a refrigerator, -70 fridge, and keep them. These tumor tissues can be used to study new cancers, to study the genetics of this tumor, and to even determine whether this particular drug that is supposed to work for this particular type of cancer will work for this particular patient or not. We can use those samples to determine all of this. We are involved in prevention and screening programs, like I mentioned earlier as well. I already mentioned tissue banking, both fresh and archival. Also involved in forensic pathology as well. In vitro drug testings can also be done by the pathologists as well. We are involved in research and drug development. We manage quality systems as well. We are involved in coroner's autopsies. For instance, we are involved in coroner's autopsies, and we determine the pathogenesis of the disease, the mode of the disease, the mechanism of the disease, and we're able to give statistics about why and what is killing our people on the roads, road traffic accidents, occupational hazards, work sites, drugs, even in hospitals, treatments new treatments fail, autopsies are performed, and we determine why the patient actually died. Hospital autopsies are used for teaching. No medical students should go through medical school without having done autopsy dissections. The anatomy demonstrations are actually autopsies as well. We are involved in teaching and research, and we educate other colleagues as well. Okay. Then what we expect from to see in our forms, I probably will talk about this later, but the form needs to be filled properly with all the biodata. We need the requesting hospital. We need you to tell us the nature of specimen. Is it on the left or on the right side? Is it a lumpectomy, quadrantectomy that you took out? We need to know if this patient has had the biopsy done before. Who is the attending physician needs to be signed because it is a consultation to another consultant. What type of materials do we work with? We work with core needle biopsies, incisional biopsies, excisional biopsies, fine needle aspiration, exfoliative cytology, body fluids. We work with all of those, and we do different, probably because of time, I will not be able to go into the details of what we do with each of these specimens. But for autopsy, I think I need to mention that autopsies are of two types. There can be coroner's autopsies, there can be hospital autopsies. Hospital autopsies are requested, and the patient died under the care of a doctor. And the doctor wants to know why the patient died so that he will be able to use this knowledge to treat the next patient better. In a coroner's case, we want to know why the patient died, who killed the patient in some countries, what mode or portal of death did the patient die through, and how can this be prevented in the future. Autopsies will usually take 2 to 3 hours. The death certificate should be ready within 24 hours, and in 2 weeks, a complete report should be ready, barring extenuating circumstances. What our reports should contain, they should contain the lesion, the type of lesion, the grade of the lesion, the stage of spread of that lesion. It should also contain the prognostic factors. I should not give you a breast cancer report without telling you whether there's lymphovascular invasion, whether there's how many lymph nodes are involved. You understand whether there's lymphocytic infiltration, whether there's necrosis, and all those parameters depending on which one we're looking at. I should not give you without telling you the type and the grade of the tumor and the extent that the tumor has spread. We can also suggest therapy. We usually would do immunohistochemistry and determine that this patient, or special stains, and determine that this patient will benefit from this type of treatment or that type of treatment. We had a lecture yesterday on the MAPTERA, and CD20 positive tests, lymphomas, would respond to MAPTERA. But if the tumor is not CD20 positive, if you use MAPTERA, which is very expensive, 250, 300, I'm not sure of the price now, you are wasting the patient's time and we're wasting everybody's time. So you need the pathologist input in all this as well. What is our report? Our report comes as histology reports, cytology reports, or the autopsy reports. Let me state here that the results from the lab is the outcome of tests or series of tests without recourse to the patient's clinical status, and therefore is of little relevance to the clinician. Let me repeat that again. The results does not take into cognizance the patient. It's what comes out, the raw data that comes out, unprocessed, unanalyzed, and the deductions have not been made. The laboratory report, however, is a sum of all deductions made and issued by the pathologist after he has analyzed the specimen, the patient specimen, the results, and juxtaposed it against the patient's clinical information. What does the consumer, the patient, want? He wants a high quality report. He wants it at his convenience. He wants it to be fast and accurate, and he wants to be able to trust and be confident in our report. The clinician wants us to be able to give him a fast and accurate report. It's understandable and it should be useful. We should not write so much jargon in our reports as well. And we should give direction as to what therapy the patient can benefit from and what form of monitoring the patient will be able to benefit from. What can we not do without? Let me, is a recap now, I'm rounding up this. Relevant clinical information and physical examination findings are of utmost importance to the pathologist. Relevant radiological and other laboratory investigations are very important to us as well. Relevant intraoperative findings. If you open the patient and there's a hole, you say the patient has a frozen pelvis, you need to be able to tell us that where you took a small piece, we need to know what exactly you saw. Previous drug use, radiological treatments, all forms of intervention, we need to know about them. Well-preserved tissues and well-stained slides are the bedrock of a good pathologist's practice. So we rely heavily on the clinician as well as on our other ancillary colleagues in the laboratory to be able to give you the best in terms of quality. What we say to the laboratory staff, even though we stand at the apex in the laboratory, we value your role in making our work come through. What we say to the medical students, the pathologic basis of disease and the illuminating scale of clinical autopsies is central in measuring accuracy of clinical diagnosis and management of the patients. What we say to the pathologists, a well-rounded education can open up more possibilities for the future. What do we say to the resident doctors? The value and role of the pathologist in making greater sense of disease mechanisms and the scientific basis of disease is advancing by the minute, and therefore everybody must keep abreast of that. What do we say to our colleagues? As good doctors, keep an open mind. Thank you very much.
Thank you very much. So Taiwo is a medical graduate of the University of Ibadan and a fellow of the National Postgraduate Medical College of Nigeria, Faculty of Pathology, the specialization in medical microbiology and parasitology. He's been a lecturer in medical microbiology at the Ladoke Akitola University of Technology and a consultant microbiologist to the Lautech Teaching Hospital for over 17 years. He heads the Clinical Microbiology Laboratory and chairs the Hospital Infection Prevention and Control Committee, as well as the COVID-19 response team. He was a former dean of the faculty and provost of the College of Health Sciences. He's also the current editor-in-chief of the African Journal of Clinical and Experimental Microbiology. So he's going to give us the microbiology perspective.
Okay, thank you very much. I also appreciate the coordinator, General Musu, for inviting me to be part of this program. I think it's a very laudable program. which is timely and really welcome as a way of bridging the gap between the pathologists and other clinicians. And I'll be talking from microbiology perspective. All other speakers have done wonderfully well. So I'm going to summarize, I'm going to present a summary from clinical microbiology perspective so that I don't waste our time. So let me start. This is the outline. I will give a situation analysis of the gaps that is currently existing between pathologists and other clinicians, enumerate the essential roles of pathology, and I mean clinical microbiologists, and then what do we do to close those identified gaps, and then I summarize. Now, I'll start by starting with a recent publication by Iregu et al., which was published this year, I think early January. It was a cross-sectional survey of about 283 physicians that were present at the annual scientific conference and All Fellows Congress meeting in Owerri in 2018. And they performed this survey based on their experience from the global PPS, which some of the authors in the article conducted in their facility in 2015 and 2017. And they found there were suboptimal utilizations of the clinical microbiology laboratory. And so they conducted this questionnaire survey, and it cut across physician, various disciplines, surgeons, family physicians, internists, pathologists, and so on and so forth, as you can see on the slide here. And the outcome measure of that study was a good or poor utilization of clinical microbiology laboratory for diagnosis of infection. Now, this is their findings. The utilization rate that they had was, they said, good utilization of 66%. But these are subjective analysis, which the authors addressed as part of the limitation of their study. But then it provides an overview of what is going on with our own local data here. So good use of the laboratory, 66% of the study population. But now 60% always use the laboratory, and 50% very often use the laboratory. So they consider that as good use of the laboratory. And then we have poor use of the laboratory, 34% of the study population. And that included 12% of occasional user, 14% of those who use it not often, 6% who rarely use the laboratory, and 2% who never use the laboratory. And interesting findings, the factors that they felt were responsible for poor utilization from the respondent, their answers. Those among those who had poor utilization of the laboratory. One was physician reliance on clinical diagnosis, 40%. And this was actually premised on the fact that the physician assumed that the patient cannot afford the cost of the laboratory test, but they can afford to buy expensive antibiotics, for example. So 40%. Prolonged turnaround time for laboratory test result, 17%. Physician knowledge of potent antimicrobials, which since if you know the antimicrobial data, let's say you can go ahead and prescribe based on empirical therapy, empirical diagnosis. Lack of access to medical microbiology laboratory, 14%. Either the facility don't have microbiology support. Absence of pathologists to assure quality of test, 12%. And then about 9% of those, that's 9 out of 97, said there's no need for the laboratory to manage patients with infection. So these are some of the things that I feel are the gaps that we need to look at and see how we can close or narrow this bridge. So I'll talk about the roles, the essential roles of microbiology. I believe the audience for these programs are medical and dental practitioners as advertised. So I want to believe that we all know what we all know what pathology is, because all of us have actually gone through pathology training at one point in time in our training. Okay, but a clinical microbiologist in Nigeria is a physician who specializes in that laboratory aspect that involves diagnosis of infectious disease using laboratory armamentarium. So I want to describe discuss the role of pathologists or clinical microbiologists in the laboratory, looking at it, the role within the laboratory, four walls of the laboratory, and the role outside the laboratory. And from there, we can see where gap exists and then provide solution to how this gap can be closed. So the first is the diagnostic role, and that is what every pathology is. I mean, you are involved in diagnosis. But what is our role in diagnosis within the four walls of the laboratory? Our role is to provide laboratory management leadership in the laboratory through the laboratory quality management system, which are coordinated activities that we need, that are necessary to direct and control the laboratory with regard to quality. Everything about the laboratories we have been talking about is about quality. And what is quality? Quality is accuracy, reliability, and timeliness of reported diagnostic tests. That is just, if there's no quality, there's no laboratory. And so the main role of a clinical microbiologist is to ensure that our results are accurate, and not only accurate, they are precise, and they are reliable, and then they are released at the time when they are needed, so that they can influence decision in clinical management. And of course, the quality assurance, which has been discussed widely, and control of all laboratory procedures, the pre-analytical process, the analytical process, and the post-analytical process are very germane. And that's why we are there as clinical microbiology, to ensure that that is done. Of course, we have to ensure standards and regulation. I just picked all these two out from the laboratory quality management system. It's a gamut of 12 quality system essential that are necessary to make sure that the laboratory is well positioned to give accurate, reliable, and timely results. And so, external quality assessment is very, very key. I think Dr. Kingsley Akaba last week talked about the issue of essential quality assessment. Accreditation for service and training, very, very germane. That's what our laboratories should work towards, particularly the ISO 15189, which is what the standard is. When the standard of the laboratory is high, you won't have any problem with patronage from the other clinicians, including international recognition. So this is what we should really work towards, ensuring that our results are reliable. And of course, the other aspect there is training and retraining to acquire skill and competence. Dr. Kingsley also talked about competence in areas that are not probably very common, because the microbiology world is changing by day. Pathology is a dynamic field, and so we need to acquire skills in this other area to increase the diagnostic scopes of our laboratory. Infectious diseases, clinical virology. We have a very good example in Dr. Adeola Fawotade, who presented last week. Because of the training that she has acquired in clinical virology, she was able to interface in this ongoing COVID, and has been a pillar in Oyo State EOC, and even in the hospital in UCH there. So this is area that I think we should train. Who are the people to train? We train ourselves. We acquire training. We keep on training and retraining ourselves. Our resident doctors, we train in such area, particular area of molecular biology techniques, which is what is increasingly being used in the bioinformatics, public health, quality management system, good clinical practice, and good clinical laboratory practice standards. These are our roles, so that our laboratory can actually support not only routine diagnosis, but clinical trials research. Our laboratory should be able to support that. That's our role in the laboratory. What of research? It's very, very germane. I think all the other discussants have mentioned research, but our research as clinical microbiologists should be something that is multidisciplinary. You are able to liaise with your clinical colleagues, including basic scientists, in translating what has been done to clinical use. Diagnostic, somebody talked about diagnostic and development and methods in terms of development, in terms of testing, in terms of validation, in terms of verification. These are our major roles within the lab. Early phase clinical trials of drugs or vaccines, they are our role as clinical. We should be involved, and that is very, very germane for us. What is outside the roles outside the laboratory? I don't divide it for convenience. I'm talking about our roles within the facility, within the community, in the academic institutions. Clinical care. Clinical care, we all know, is interdisciplinary and multidisciplinary. Infectious disease, hematologic disorder, cancers, metabolism. These are multidisciplinary diseases that we think requires fit. And so pathology must be involved. It has, I think the other discussants had elaborated on this, and I think this is a very good one. So in treatment, in prognosis, in monitoring, and clinical microbiologists are involved in clinic consultations. We also run clinics, the general medicine clinic or the STD clinics, which is, is an area where you interface directly with the patients. And of course, receive clinical consultations, and through this we can contribute to clinical care. Our thought or our philosophy should be patient-centered pathology practice, not just dealing with samples. It is samples that we are dealing with, or the slide that we are looking at under the microscope is a patient. And so we should see it that way, that specimens are ultrafiltrate of blood, like it was well established. And the life of a person is in the blood, as a popular saying. And so we should see our work as not only just laboratory, but as patient-oriented. And of course, we're also involved in screening and monitoring of disease constitution, use of biomarkers, and POCT. I think the chemical pathologists emphasize on oversight function on POCTs. The POCTs that we use in microbiology, they should have oversight. They should be validated from time to time, maybe once in a year, so that we know that what we are doing is actually correct. Of course, another major area of clinical microbiology practice major role is in IPC and antimicrobial stewardship program. This is also a multidisciplinary team, but the microbiologists must take a lead. We must play a leading role in area of IPC, and both in the practice, both in the principle of IPC, and in surveillance, which is the backbone of IPC, in monitoring intensity, spread, severity, and impact of disease, and impact of interventions, infectious diseases, surveillance of antimicrobial resistance through the global PPS. This is a very germane function of clinical microbiology. And I want to see, let's see a scenario, what is going on with the COVID-19 pandemic, why IPC is actually important to us in Africa, and why microbiologists must really be well involved in this one. Look, this is an analysis of the critical care capacity that was done by the CDT-EP, looking at the critical care capacity of 54 African countries. And looking at the hospital beds that we have now, the physician, the ICU bed, the ventilators, the physician anesthesia provider, and the non-physician anesthesia provider. And the summary is we have very low critical care capacity. If this pandemic explodes, we are already in the accelerated phase. And so IPC is the key. If you look at the picture on the right there, this is just a scenario that this is what we have if we have 30% severe cases of COVID requiring health service care that will require hospitalization. Percentage of those ones will require ICU admission, and about 2.5% require ventilator assistance. And look at it, only very few African countries actually have the capacity when at 30%, at 50%, at 70%, and 100% scenario. So the bottom line is that IPC is key to what, and this is an area that the clinical microbiologists must take a very leading role. We are already doing that. I think that is an example of what is going on. Professor Laika in the NCDC and some other people, Professor Bushola, all of them are involved in this kind of a scenario. And so I like the definition of the current definition of IPC. It says it's a scientific approach with practical solutions designed to prevent harm caused by infection to patient and healthcare workers. So it's both patient and healthcare workers. Grounded in principle of infectious disease, epidemiology, social science, and health system strengthening, and rooted in patient safety and health service quality. This is a coincidence, definition of what infection prevention and control is. And this is where microbiology should actually take a lead. And surveillance, which is the key, is the backbone of IPC, is the ongoing systematic collection, analysis, and interpretation of and dissemination. So surveillance of infectious disease is actually information for action. Now, where we don't have a measure, you cannot improve it. That is the popular saying by Lord Kelvin, that if you cannot measure it, you can't improve it. So surveillance is a measure of IPC, and is an information for action, is a cycle. You continue to do it. It's not a single and one-off survey, it's a continuous act So this is a very key area for clinical microbiologists. What about guidelines and recommendations? We have talked about, the other presenters have talked about what the clinician, we expect from the clinician, arm of result. If you bring in garbage, it is going to be garbage out. But it's not, it doesn't end there. What is our own role in ensuring that they don't bring garbage to us in the laboratory? That's why we must develop guidelines and recommendations on things like text ordering, appropriate test to order in appropriate situations. This should be contained in our laboratory handbooks, which are available to the clinicians who are our customers and even our patients, so that they will understand what test to order. That is what test to order in a particular situation. If, for example, you have anaerobic infections, you don't just collect sample and send it to the laboratory. The organism will be dead before they get to the laboratory. You're going to get no good result. Patient preparation, the time of collection of samples, the type of sample to collect, the preparation, the collection, the storage, the transportation. All these are things that should be made available to the physician so that they don't bring in garbage to the laboratory. Yeah, it's the same thing. Guidelines for IPC, guidelines for ASP. The microbiologists should be well involved in this, and of course, teaching of pathology. We can't but emphasize this. Teaching of pathology at undergraduate level and postgraduate level is very, very germane. We need to begin to look at the curriculum of undergraduate school, because opinions are formed at this level. Most of the people that are not probably making use of the laboratory very well are probably because they have, they have developed an opinion at the undergraduate level and they go ahead and do this. So we need to do that, and I'm happy that some institutions are already doing that. Dr. Kingsley talked about introducing concept of quality management system at early level. Concept of research. This is completely absent in undergraduate practice. Research is not really. I'm talking about the principle of research, particularly from the laboratory perspective, is what we should, as much as possible, so that our undergraduates are already well ahead of this. In some climes, they now introduce concept of intercalated program, concept of MD, PhD program at undergraduate level, and these are, of course, teaching of IPC, teaching of antimicrobial resistance and therapy, very, very germane in medical school. So these are areas that we should look at. So what do we do to close the gap? Number one that I think we should is availability of laboratory physicians for performance of their roles within and outside the laboratory. Very, very important. I've had issue that if the clinician cannot find the pathologist there, they will talk to somebody else. So it's very important. Continuous engagement of clinicians in offering holistic care to patients. This is what we should continue to do, and this forum is one of them. Interdisciplinary meetings, I think that has also been mentioned. Communication, feedback. We must listen to feedback from our colleagues through different meetings, clinical pathology meetings, as mentioned, ground round, morbidity and mortality meetings. We should participate in all this. Formal and informal discussions, conferences, seminars that cut across. Very important. Research collaboration, we can't but do this. Cross-cutting research, forming ourselves into research groups, consortia, and these are clinical research, clinical trials of diagnostic of drugs, including herbal medicine, who are shouting about herbal preparation. We have a role to play in terms of translating what is done in the basic end to the clinical end for use of our patient. And of course, the CMP, the the Nigerian Society for Infection Control, the clinical microbiology, they should, like Dr. Jumoke last week, we should be resource materials. We should be the resource for pathologists, other clinicians, scientists, and of course collaborate with other international bodies on this. In summary, what we need to do is to identify gaps in our pathologic practice as it relates to clinicians, other healthcare workers, management community, improve our practice by implementing and maintaining quality standards. There's a continuous quality improvement, and then we constantly engage clinicians to continually bridge any identified gaps. So I thank you for listening.
Now we're going to move on to our panelists, and we have three of them who are going to just give us their own views and experiences on the use of the pathology department, or what they expect from pathologists, where they have had shortfalls and what they think we can do to improve. The first panelist is Dr. Abimbola Abolarinwa. This is my sister, my namesake, and a colleague in whom I'm well pleased, making waves in a very unusual field for women. She is a urologist, and I think for now, probably the only consultant urologist that is female in Nigeria. Dr. Abimbola Abolarinwa is a fellow of the West African College of Surgeons with specialization in urology. And she is a lecturer and honorary consultant urologist to LASU, Lagos State University Teaching Hospital, and a lecturer at the Lagos State University College of Medicine. Dr. Abolanrewa, please just give us your perspectives on this.
Thank you very much, General. I'm happy to be here, and we are actually 5 female urologists in Nigeria.
Oh, 5 now. Okay.
I have 4 younger sisters.
That's
This lecture pleases me because the basic relationship as commonly perceived in pathology is pathology for histology is what surgeons see as important. That's okay. That pathology is only just for doing histology. Because we provide the samples, it's basically like you're providing the meats and then the pathologists are cooking it in the kitchen. Well, it presupposes that morbid anatomy is the only pathology subdivision that is important to surgeons, and that's not true. There's much more. I would like to break it down to clinical, teaching, research, and publication, and medical legal issues. Clinically, pathologists help us in definitive diagnosis. You know, whenever we are having our morbidity and mortality meetings and we are arguing for and against the pathology, and eventually there's a postmortem report, everybody sits down to wait because we know that whatever is said there is final. So whoever was actually in line with the pathology starts jumping and like, oh, we got it from our clinical history and management. So definitive diagnosis basically is from pathologists. And of course, in it, they also help us in staging, which helps us in our decision for treatments and also prognosis to discuss with the patient. And then, of course, pathologists help us in co-management. I really need to stress this because of the aspect of multidisciplinary care. Like, some patients may present with priapism. I'm using urology as a focus for surgery here. And the patient may have leukemia. All we just need is a full blood count. Just like what Dr. Bello Manga said, that full blood count is a full story. All you just need is a full blood count. And when you see a very terrible leukocytosis, you may now start considering that the cause of that priapism is hematological, and then you call in the hematologist, and then they take over with the oncologist in managing the leukemia. But the patient presented with priapism. So we don't just look at it as this is just a surgical problem. There may be an aspect where we have to co-manage with the pathologist. Multiple myelomas presenting with priapism or with hematuria, we've seen so many of them. Of course, we manage urosepsis, we manage Funias gangrene with the microbiologist. In fact, there was a time that all the hypospadias repairs we had, the wounds were breaking down. We called the microbiologist in LASU. They took some culture swabs of the ward, and they were able to find out that there were a lot of organisms there that were predisposing our patients to having poor outcomes. So they had to close down that ward, they fumigated it, opened it up in 2 weeks' time, and then we didn't have all those issues again. So in cases of sepsis, we manage a lot with the microbiologists, particularly when it has to do with multi-drug resistance, and they give us advice. Disorders of intersex, I want to stress that, especially the cases of congenital adrenal hyperplasia with salt losing. Chemical pathologists come in with that. And then frozen sections in surgery, when we are having surgical excision of tumors in theater. Sometimes we've had to liaise with the pathology lab in LASU. It takes a while to prepare frozen section, but we can plan this selectively. And then when you're excising, particularly in radical cystectomies, where you want to be sure that your ureteric margin is free of tumor before implanting it in the colon, before diverting it to the colon, we do frozen sections. So these are some of the ways we can clinically co-manage with the pathologist. Of course, teaching in undergraduates and postgraduates is very important. They do rotations and postings, particularly postgraduates. We need to emphasize to the younger generation earlier in life that there's something called multidisciplinary management. And I think that needs to be really knocked into the heads of medical students. Because a lot of times when they come to clinicals, they think that they're going to throw away their anatomy and pathology. So we keep teaching them, making reference to go back to their basic medical sciences and basic clinical sciences. And research and publications is very important. There are some surgical journals that will not really accept your manuscript unless you have the input of a pathologist, or maybe like slide pictures from the pathologist when you're discussing a particular thing. So it's very important. Really, there's no research that is in isolation. I find it strange when some university specialties, not medical, have a one author paper. That doesn't happen in medicine and all. And then, of course, medical legal issues. We've had cases where maybe some patients have swallowed drugs and they've had to come to LASU to have them removed from the abdomen, or maybe you have gunshot patients. And then even in some cases where a patient sues a doctor, the pathologists usually clear out all these things, you know, particularly has to do with maybe cases of mismanagement, alleged mismanagement by making the assessments and doing a postmortem and also. These are some of the ways to come in. Now, where we have issues actually is in availability of discussing with pathologists. The pathologists sometimes may not be so available. I put it that way because, particularly with chemical pathology, most times you just get a result and that is all we see. And then interacting, I think more of the clinical aspects of pathology is hematology, because whenever we need a hematologist, we get them easily. Even they help us with challenges with getting blood products and even advising us on what to use and what not to use. But with chemical pathology, mostly we just interface with the results and have to do the interpretation ourselves. And so I would want more pathologists to be a bit more involved in the lab than us having to interface with the laboratory scientists most of the time. And then also sub-specialization in pathology, particularly for morbid. We would like to have a uropathologist that would focus more on our samples than having a pathologist that we assess breast, that will assess colon, that will assess prostate, and it also helps us. And I think those are where the issues really are. We need that interface. We do a lot of surgical, radiological meetings, but surgical pathology is not so much. And the irony is that in exams for part 2, there must be pathological parts. So I don't know why we don't clinically meet so often. So I think we need to do this at each level where we come from, our hospital levels, and have more interaction with the pathologists beyond the morbid anatomist, so that we'll be able to see the effects that others can contribute to our care of our patients and also our career progressions. We can be mutually useful to each other. Thank you.
Thank you very much. Thank you very much. And I think we have noted those things, and ultimately the essence of this is for us to be able to come up with things that will help to improve the interaction between the lab and the other specialties. I'll now call on the next panelist, who is a pediatrician, Dr. Amina Bello. Dr. Bello is a consultant pediatrician and with a special interest in pediatric endocrinology. She works with the Citizen Medical Center, Ikoyi. She's a graduate of the University of Maiduguri and is currently a fellow at the Pediatric Endocrinology Training Center, West Africa, in Luth. Dr. Bello, please, can you give us your own perspectives?
Moderator and the respective speakers, all protocols observed. I'm glad to be here today in this meeting, and I would like to say this meeting is one that we should have more often, and I'm really glad that it's happening today. Yes, a lot has been said by the previous speakers and even the previous panelists about the interaction between the pathologists and the clinicians. I wouldn't want to go talking about that again, but what I would, the point I have noticed is that most problems from the clinical pathology aspect are said to have arisen from the clinicians, being that about 65% of error problems arise pre-analytically. So the pathologists have given us a task, kind of to address. Now, what are we the clinicians doing about that? If most of the problem they get from the lab is pre-analytically, then what do we do about it? I think there should be more interactions. There should be more collaborations, because like already speakers already said that most of these young doctors coming up, they don't even know which why certain tests are done and why it's being done. So I think we should have more education, more collaborations, more interactions, to put us through what should be done and what should not be done before it gets samples to the lab. That's very important, because the aim of healthcare in general is to meet patients' wellness, safety, and satisfaction. If at the end of the day, you have done a clinical diagnosis, and to confirm that diagnosis, there's a delay in confirming the diagnosis, it ultimately affects on the patient. So it's very important that we do our own part as clinicians, because we have already noticed now that 60% of, or over 60% of laboratory problems come pre-analytically. And to make a diagnosis for patients, we rely at least 70%, to make a confirmed diagnosis, 70% relies on the pathologist. So we need to do some work. Then on the part of the pathologist, somebody has said that sometimes it's what you bring in was what you give to you. Garbage in, garbage out. I think we should not take that approach. If, as a pathologist, you notice that the sample that was taken, the forms are not properly filled, the sample are not adequate enough, the method of collection is not appropriate, I think you should not work on that sample, and the doctor should be called should be called to order immediately, and not working on the sample. And the day the patient comes for review, we say laboratory error, inadequate sampling or this and that. That will amount to waste of time of the patient and even the doctor, and delay in diagnosis. So I think I will cite an example with diabetes. Diabetes needs accurate diagnosis and continuous monitoring. It's a continuous monitoring because it helps us to monitor and alter medications as management progresses. So if you have, if for instance you take a sample to the lab and HbA1c to be done, and it's not appropriately done, probably because of a pre-analytical error, and you took it like that and did it and said it's the laboratory, it's the clinician's fault, and you have already done it. The patient comes for review. You can't monitor the patient's treatment. So I think we should work together and collaborate more, and it's not. And we should go beyond results, because sometimes we wait. It's only when we get results that we start interfacing with each other. We should go beyond that. Most of the time, it's only when you see a result that is not in keeping with clinical diagnosis that you call the pathologist. We don't work together. So I think this should be corrected. And if this will permit me, there's something that has always been bothering me about transfusion in children. I've talked to some people, but I've not gotten a satisfactory answer yet. I don't know if I should use this medium to ask that, are there no bags that can be used to package blood for children? Because it hurts when you take a 500 ml bag of blood and you end up wasting more than 250 ml because the child just needs about 150 ml or thereabout, and you waste the rest. So I don't know if this is a right if this is going to be a good opportunity to address it. Well, all well said. I think the role of the pathologist can never be overemphasized in our clinical practice. We should do more of collaborations and meetings, and a lot of education needs to be done, especially to our young doctors. Thank you.
Quite apt on the use of blood bags for pediatrics. So I'm sure Dr. Manga Bello will give a response just when we finish this. The last panelist we are going to take this afternoon is also, of course, I'm sure would have known that somebody very close to me, and short of saying I have done some ojoro, but you have to look, and when you know you have people that you can also rely. And looking at Professor Taiwo's presentation, they also alluded to the relationship between pathologists and the critical care specialists. Our fourth panelist is retired Major General Obashino Gumbi, MNI. He is a consultant anesthetist and an intensivist, former corps commander of the Nigerian Army Medical Corps, and he is presently the president of the Intensive and Critical Care Society of Nigeria, and also the first Black person to be elected as a member of the Council of the World Federation of Intensive and Critical Care. He's currently the coordinator Clinical Care Strategic Unit of the Lagos State EOC for the COVID-19 response. General Gumbi, please give us your perspective.
Moderator, and I want to sincerely thank the organizers of this webinar, that is the College of Nigerian Pathologists. Indeed, I'm a friend of pathologists, and this cannot be overemphasized because I've been used to almost all your events I've been invited to in the past few years. I want to say that this subject is very this time because the pathologists and clinicians is like a marriage of necessity to achieve one of the fundamentals of the practice of medicine, that is to restore an ill person to his normal standards of health. Also, I must say that pathologists and clinicians, especially anesthetists, we share the same, I quote, back of the screen, unquote, features compared to our surgical colleagues. For most times, our surgical colleagues are showcased when they do, they come to limelight when there's, a very important surgery that was done and so on and so forth. But nobody talks of the anesthetist. Nobody talks about the pathologist. So we share the same features in this respect. I want to speak on both as an anesthetist as well as an intensivist. As an anesthetist, more often than not, it may interest us to note that our surgical colleagues always fight with us anesthetists, that we ask for all investigations. In fact, sometimes they label us asking for serum pepper and what have you. However, we as clinicians, we know the import of asking for these investigations, and we collaborate closely with our pathologists, because we know the import of this on our patients, on the outcome of our patients. Now, I want to emphasize more on the blood transfusion services where our hematologists come into play. It's very important that we associate with our hematologists with respect to blood transfusion, because more often than not, when we are engaged in emergency surgeries, some of these surgeries demand blood transfusion, emergency blood transfusion. And more often than not, in most centers, the transfusion services are run by the medical laboratory scientists, especially after hours. I want to see a situation whereby when we request for blood for our patients for emergency surgery after hours, our consultant hematologists can be nearby, if not on site, to be able to give necessary assistance. I have been involved in a case that needed emergency transfusion, and the laboratory scientist made a mistake while doing the blood grouping. And we got the first bag transfused in a patient with APH, antepartum hemorrhage, and the patient reacted within 5 minutes. And of course, we did the normal protocol, stopped the blood transfusion and kept it, and of course, did the normal thing. It was later found out that the laboratory scientists made a mistake while doing the grouping and other things at that time. So I want to call on our colleagues that if it will be possible to actually have our hematologists nearby at times like this. Also, it's very important as an intensivist to emphasize the role of microbiologists in the intensive care unit setting. More often than not, when we have patients with sepsis, then we need the advice of our microbiologists. And in most ICUs, when I trained in the United Kingdom, whenever we have ward rounds, we have pathologists, especially the microbiologists, as part of the team at times like this. For us in Nigeria here, I don't know, maybe because of the lack of numbers, it may not be possible to have microbiologists all the time, but even if it's just once a week or thereabout, it would be a good venture to have our microbiologists join us for our intensive care unit ward rounds. Again, while in the ICU, it's important to emphasize the appropriate use of blood and blood products, especially platelets. Most patients in the ICU, especially those who spend long time in the ICU, more often than not end up with anemia. But we need the services of our hematologists to be able to quantify this and advise us appropriately with the use of blood products in these our patients. And this we have been getting, especially for those who have worked or who are working in the tertiary centers. And there's no problem with that. But for those in either general hospitals or some federal medical centers, it's important that the hematologists should be interested, just as Dr. Manga said earlier on, they should be interested in knowing what happens in the ICU of their respective hospitals. While rounding up my contribution this afternoon, I want to recommend that we should have quality assurance of some of our equipment in the laboratory, because more often than not, from experience, we have been having some results which are doubtable coming out from some of our laboratory services. So quality assurance is very important. I want to recommend this. Also, we should work on validation of results that come out from our various laboratories. For instance, in the course of my work with the COVID-19 response in Lagos State, we have had issues with some of the results that were released to us from some of our laboratories. And there was a particular instance whereby a patient did a test in one of the centers, and same day went to do the same test, COVID-19 test, in another laboratory. And we had two different results come out from the same patient on the same day. We raised this in the course of our EOC meetings, and later on we found that there was some error in one of the laboratories because the result had to be revalidated, as it were. This can occur with other investigations as well. So I want us, as our colleagues as pathologists, to look into this as well. In closing, just on a lighter note, recently, for those of us who are very active on social media, will hear that the president of Tanzania actually said that he sent samples of banana peels, samples of plantain peels to some of the COVID-19 laboratories in his capital, Dar es Salaam, and those samples came out as being positive for COVID-19. That's just on a lighter note for us. So we need to have quality assurance of our results. I must say again that our pathologists are very, very humane and an important medical specialty, and we need to work hand in hand together with them. Together, that's as clinicians and pathologists, it's a teamwork, as the last speaker did say. It's a teamwork for us. On this note, I want to say a big thank you to General Tilewa Amusu and the leadership of the College of Nigerian Pathologists for inviting me to be one of the panelists at today's webinar. Thank you so very much.
Would like to call the president of the College of Nigerian Pathologists, Professor Pio Olatunji, to please give us his own remarks and also take some of the comments that will pass for the questions. And then after that, we'll just take half a minute to round up from the 7 people who have spoken.
Thank you very much again for having me, and thank you for this important innovation and introduction into pathology, clinical physicians matter. Let me just say very quickly, let me thank our panelists, particularly the clinicians that have come and for what they have shared to us. Now, I just have a few comments on what I think we should, what I want us to bear in mind, particularly from a clinician point of view. Every laboratory form has a space for clinical details, has a space for time, type of sample, and time the sample was taken. My observation is that these areas of the investigation request forms are usually left unattended to. If a pathologist is going to do his work very well, he needs to have clinical details, age, sex, and what the clinical features of the patients are. That is a very critical omission that I've noted. Concerning time and type of sample, particularly time, I've noted that many times samples are taken by the houseman or housewoman at 8 a.m. There's nobody to bring the sample to the lab, and the sample may not reach the lab until 4 p.m. From hematology and chemical pathology point of view, these samples will almost be useless because many changes will have happened to these samples before they get to the lab. In the case of hematology, cells may, the morphology or the cytology of cells may even have changed significantly by the time you are looking at it. So I think that our colleagues should ensure that I took notice of the issue of availability, and that is an internal issue that as pathologists we will handle, because if we are asking them to make use of us and we are not ourselves available, then it becomes a little bit difficult for them. We want to promise that we are going to interact with ourselves, make ourselves available, so that the patients in particular can derive the benefits that they ought to derive from having hematologists around. Thank you very much, Dr. Amusu, for making all this happen from time to time, and also to our panelists, particularly the pathologists who have come to speak today. Thank you very much, and God bless you.
Thank you very much, sir. Please, we have addressed the questions in the Q&A. Do we have any of the speakers who would want to give a closing remark? Because we
yes,
have
ma'am.
time.
Thank you, ma'am. One of our panelists, I think Dr. Abimbola Bolariwa, certainly mentioned issues in her center she has with chemical pathologists not commenting on results. So I think that is center specific. Here in Lutz, for example, no result comes out of our lab without the chemical pathologist comment. We have a laboratory information software, and the scientists do not have the administrative right to release a result until a pathology has commented on that result. Pathology has the full right. It's only after pathology comments on the result gets out, and the LIS on its own sends the result automatically electronic to the clients. So, but they don't have that access. So every result must be commented on, whether it is all the results are okay within reference server or they are abnormal. We comment on everything. So, and that should be the ideal. So, I don't know whether your center you have chemical pathologists. Maybe we are not many. Chemical pathologists and medical microbiologists are very few compared to hematologists and anatomic pathologists. So it's possible that in some centers they don't even have any chemical pathologists to comment on results. So there might be a need for regional collaboration. Maybe technology can help in that area. In South Africa, for example, they use technology, NHLS. You don't have to be a consultant in a particular hospital to comment on hospital's results in that region. So anybody, someone's on duty and can use technology to leverage that. So we should engage our chemical. If there are indeed chemical pathology in that lab, they should be engaged and encouraged, to meet the expectation of the clients. There should be regular meeting between the physician and the pathologist to bridge that gap. Thank you.
Thank you very much. Dr. Olomanga.
Okay.
Yes, I would like to just comment on Dr. Bello's comment on pediatric blood bags. So that transfusion quantity for pediatric patients. We actually have pediatric blood bags used. It's about half of the adult blood bag, but I still appreciate that that might not be feasible for use in the neonatal period. So if I could just have a permission to share my screen, I'll just show you like some small bags that are used, about 75 to 80 mils aliquots, which are sometimes used in the neonatal period. But unfortunately, these bags are not readily available in the country, but I think the onus is on us, maybe through the National Nigerian Society of Hematology and Blood Transfusion, to make sure that we have some of these bags available or encourage suppliers to bring it in, because I totally agree that it's unfair for you to have a whole unit of, we all know how valuable and how scarce a resource blood is, for you to waste it away. So these pediatric blood bags would actually help. I don't know, do I have?
Yes, please. Yeah.
Yes,
Yeah, so these are just small, very lovely looking aliquots. It's just about 75 to 80 mils. So I think these would be really ideal in the neonatal setting. And if there's a way that we can encourage suppliers to bring in so that hospitals can have access to it. So thank you very much. And then for my colleague, the anesthetist, about blood transfusion reactions. You know, I think every hospital should actually have a hemovigilance system so that any transfusion reaction is actually investigated to the root cause. So it's not just about the hematologist. There are processes in blood transfusion chain. So a hemovigilance system in place will actually help in addressing some of those issues. Thank you very much.
Thank you. Dr. Ola, half a minute.
Yes. I just want to comment on the issue. Somebody asked a question about autopsy rates going down. The discussion we have. The reason why autopsy rates are going down are very many, and it's not only in Nigeria, it's everywhere. But I just want to use this opportunity to appeal to our clinicians that one of the major roles the pathologist plays in clinical services is in audit and governance. This audit and governance role would be complete and would be more precise when they allow us to perform autopsies. I know it's difficult sometimes for cultural reasons, also for some patient relatives to agree, but if we set it as a protocol and as a policy of the hospital, I think it would go a long way in elucidating a lot of the reasons why patients die in hospitals, and it would also help us to have opportunities for teaching and for learning as well. Thank you very much.
Thank you very much. Professor Taiwo, please.
Once again, I want to thank the organizers. I think most of the, I don't have any specific comments. I've answered the few questions in the Q&A section. But I think the observations of all panelists is well taken, and I believe continuous engagement is very key in providing holistic approach to patient management. And like the president said, we'll put our house in order. There are some internal issues which I believe we put in order, and then continue to work together towards one goal, and that is quality provision of services to our patients. So I want to thank you once again for giving me the opportunity of participating in this program.
Thank you very much. Dr. Ola, I'm just going to ask a question, just a yes or no. There's a question here that says that is there a maximum time limit before samples that are banked are discarded?
Yes, I was trying to answer. Yes, I'm trying to answer that question. I was trying to answer that question now. There's a yes and a no. Yes, because if you have space constraints, your hospital can decide on policies of, okay, I'll keep it for 100 years, for 50 years, for 30 years before I discard. But on the alternative, they can all be moved to a regional center where these samples are kept, because we can study some diseases that in 50, 60, 70 years may emanate, and we may need to look at these old samples to be able to answer some questions there.
Thank you very much. We will address the few questions left in the Q&A even after this, so that because I know some people are also working on to join another webinar. But I want to thank everyone for being part of this. It's supposed to be an initial engagement. We hope that after this, we'll be able to go back and actually interface with the pathologists in our different centers, and pathologists as well will be able to properly engage with the other clinicians to properly address some of the needs. Sometimes they do not know what we are capable of. We should also look at the comments that have been raised, particularly like that raised by Dr. Bello on unacceptable samples that are treated, and then people come for the results, and it's at that point that we tell them, oh, this result will not be live. We should actually have a way, once we know that this sample is unacceptable, what we're supposed to do is to actually reject it and inform the client, the requesting physician, so that we save time as well. I also just felt, because it's a very wide subject, what pathologists do are very, very wide. So we're not able to address everything in this. But for instance, when we talk about even provision of blood, when you're getting your patients ready for hematology, there's also the option of the autologous blood transfusion. So if we actually get our patients ready, you can talk with your hematologist and they'll be able to provide you with enough units of blood, so you do not even need to get blood for patients from outside. I don't know if Dr. Lawal has anything to say. He's the secretary of the College of Nigerian Pathologists.
Thank you very much, Ma. I can see we are 1 hour behind schedule, yes, but more than 100%, okay, let me say like more than 90% of those that joined are still online. So that just shows how successful this has been. Okay, let me just quickly make my contribution. Regarding young doctors, we have a crisis of appreciation of pathology among young doctors. And I think we pathologists and other clinicians should help the young ones. For instance, some hospitals, they have rotations in the labs. Some hospitals, some other clinicians believe that there's no what's the house officer doing in the lab. But I think for those that have rotated through my lab, we've been able to show them some appreciation of pathology, and they understand better the basis of some of these diseases they are treating, and they actually appreciate the 2 weeks posting in my department. So I want to appeal to other pathologists, and whenever you have house officers posted to you, please do your bit to make them understand pathology. I want to also appeal to the clinicians. When you are doing your ward runs and house officers are there, just don't just limit them to runners and chasing results. Ask them about those results, about the clinical interpretation, about the appreciation and all that. I think we will, because of the fact that the pathology is a block posting in medical schools, they just want to do what people call let my people go, and most of them they don't appreciate it, and it also affects their practice in the long run. Lastly, I'd like to thank General, but I can see with the way we've attended this particular program, we will work on maybe like a quarterly, what do you call it now? We'll bring a topic, multidisciplinary, maybe case review, where pathologists and other clinicians will look at how to tackle it to make it more robust. We know we've already talked about the deficiencies regarding pathologists not being there, clinicians not feeding results and all that. But I think this is a step forward, and we're going to consolidate on this. Thank you very much.
Thank you very much. So we would be signing off now, and please know that this is also to let us continue this engagement in our different centers. Pathologists, please be open and try and have this follow-up based on your centers, and have the local collaborative meetings to be able to break down any barriers between the clinicians. And also for our colleagues from other specialties, please feel free to go into the lab and ask for the pathologist and share your concerns and let it be properly addressed. The ultimate goal is for us to be able to do what is best for our patients And once we're all able to do that in a multidisciplinary place, I think it will make the work lighter, and it would also make our patients healthier. Sorry, we are unable to see any points available. We are working on that, but let us continue to build on this essence of teamwork, and we hope to see you again soon. Thank you very much. Thank you very much, our panelists.
Thank you.
Thank you very much, Madam.
And
thank you to all our panelists.
We hope you will come again when we call you, and you would
absolutely
forgive our initial shortcomings. That made us take an extra time, but also the presentations were also very interesting.
Thank you very much, General Musi, for asking me to speak today.
Yeah. Thank you, General Musu. It was lovely being here. I thank all panelists as well. God bless.
This is one of the best news of this year for me. I think it's the right step in the right direction.
All right, thank you all.
Thank you.
It's been a long session, but I can see that it has made some impact, and we hope to consolidate. Thank you, General. I hope people have thanked you too.
Thank you.
I was in the.
Thank you for having us.
Thank you very much.
You're welcome. Bye.
Thanks for your presentation. And you kept with the time.
Thank you.
Thank you, Ma.
Thank you, General.
Thank you. Thank you very much, Dr. Bello. Thanks for coming. Thanks for accepting the invitation. Thank you, Dr. Ola. Thank you, everyone.
Thank you.
Thank you, Ma. It's our pleasure.
Oh, thanks a lot. Thank you very much.